So, good afternoon, and thanks Dipankar for including me in this exciting instruction course. I just like to tell about that Somshilas, that one. We have seen syphilis presenting as a nodular scleritis, and that is also one should keep in mind. So, I'll be talking on stromal choroiditis. So, stromal choroiditis is not rare. The common cause is sympathetic ophthalmia, Vogt-Koenig Harder disease, tubercular choroiditis, sarcoid positive uveitis. Unfortunately, we don't have the pathology specimens of except sympathetic ophthalmia in many of these entities. So we don't know the pathophysiology or pathologic correlation. So sympathetic ophthalmia, as you know, rare bilateral granulomatous panuveitis. Exciting eye is following surgical or accidental trauma to one eye. Sympathizing eye is the uninjured eye developing uveitis after a variable latent period 5 to 60 years. And here is an example of sympathetic ophthalmia. You can see that multiple choroidal nodules are seen, and there is an optic disc also has nodules. And what we see in pathology is a diffuse granulomatous uveal involvement with lymphocytes, epithelial cells, giant cells, and occasional eosinophils. The eosinophils are present in the early course of the disease. Relative lack of retinal inflammation. You don't see retinal inflammation in sympathetic ophthalmia. Absence of inflammatory reaction in the choriocapillaries. Early enucleated eyes demonstrate a sparing of the choriocapillaries. We can see the Dallen-Fuchs nodule. Granulomatous process may extend to the scleral canal and optic nerve. Here is the example of Dallen-Fuchs nodule clinically on fundus photography, and here is one of the histopathologic example of cut section of the globe showing diffuse thickening of the choroid. And here is the Dallen-Fuchs nodule. You can see the RP is elevated. Underneath the RP, the choroidal granuloma is seen, and the choroid is diffusely infiltrated with inflammatory cells comprising of the lymphocytes, and there is a collection of epithelial cells are seen as a form of granuloma. And there is a whole section, whole eye images of a sympathetic ophthalmia. You can see superiorly there is a perforation of the globe, and there is a diffuse thickening of the choroid, and there is a sensory retinal detachment. And here is the histopathologic examination of the thickening of the choroid, and you can see that granuloma is seen underneath the RP, epithelial cells, and lymphocytes, and there is a diffuse collections of the lymphocytic infiltration, and choriocapillaries is remaining uninvolved. So in case of Vogt-Koenig Harder disease, specimen is hard to get, and you can see that some Dallen-Fuchs like nodules in the periphery, and this is in the left eye. And here you can see the diffuse infiltration of the lymphocytes, and there is a granuloma also, as we see in case of sympathetic ophthalmia. And here is the case of BKH, where the retina is not involved much, and there is a secondary changes in the retina, and there is a diffuse infiltration of the lymphocytes in the choroid. We described clinical pathological and immunohistochemical correlation in the case of BKH with Dipankar, and this is a case where immunohistochemical study was done in Dipankar's lab, and you can see that the diffuse infiltration of the lymphocyte seen in the choroid, and this is a higher magnification, and you could see that there is a CD3 predominantly involved, and few B cells were also seen, CD20 B cells. So shifting gear from the non-infectious uveitis to the infectious uveitis, tuberculosis. Way back, about 40 years back, we have got a patient who had a multiple subretinal abscess. We thought that this could be due to sarcoidosis because his QM test was positive and serum ACE was elevated. But the patient did not respond to the steroid, worsened, and then even he started of the antitubercular treatment. They didn't lead into panophthalmitis. The eye was to be eviscerated, and the eviscerated globe, to our surprise, showed myriads of acid-pass bacilli in the retina, within the retina and the subretinal space. There is an article by Dr. Professor Narsingh Rao has described tubercular uveitis, described the presence of mycobacterium tuberculosis in the retinal pigment epithelium. Here you can see the retinal pigment epithelium is necrotic, and within the necrotic retinal tissues, we could see that multiple acid-fast bacilli. So it is possible the direct infection of the tubercle bacilli can occur in the retinal pigment epithelium in case of multifocal choroiditis due to the tuberculosis. And this is a case of tubercular serpiginous choroiditis published by Padma Malini and Dr. Narsingh Rao, and the patient has typical fluorescent angiogram picture of serpiginous choroiditis, and OCT findings show subretinal scar, and here is the fundus photography and fluorescent angiogram, autofluorescence, very characteristics of serpiginous choroiditis. This patient had undergone had retinal detachment and undergone retinal biopsy, retinochoroidal biopsy, and the retinochoroidal biopsy showed inflammatory cellular infiltrate, predominantly lymphocytes with epithelial cell granuloma. The giant cells is seen in the picture. I worked on during my fellowship in 1989. 2 patients of AIDS had died of the peculiar choroidal lesions. As you see, there is a choroidal granuloma seen. Both the patients' eyeball was received on autopsy, and autopsy examinations, this is a gross photograph taken by me, showed choroidal infiltrate. This choroidal infiltrate showed acellular eosinophilic material, which on GMS10 showed pneumocystis kinase cyst. In electron microscopy showed typical characteristic pneumocystis kinase cyst with multiple daughter cyst with inside encapsulated material. So this was my first publication as a fellow. There is a recent article in JAMA Ophthalmology 2025, why I want to highlight. This is a parasite, Strongyloides stercoralis. The patient died, and the autopsy of the eye from the choroid, autopsy of the patient's the eye tissues are available, and you can see in the arrow mark there is a parasite sitting over there in the choroid with diffuse infiltration of the inflammatory cells. And this patient was subsequently on high power magnification. Parasite was seen, and this lung also contained the same parasite. So what we are seeing many phases of choroiditis, we are not able to identify and call it as autoimmune, could be due to some infectious organisms including parasite. So in conclusion, stromal choroiditis is quite common and can be due to non-infectious like autoimmune, VKH, sympathetic ophthalmia, and infectious causes. Histopathologic studies are scanty except in sympathetic ophthalmia, but nowadays with the molecular biologic study and immunohistochemical study, the pathophysiology or pathogenesis of the disease can be elucidated elegantly. Thank you very much for the wonderful.
Thank you, sir, for this wonderful presentation. Any question to sir? So, sir, is there any difference between a Dehlen-Fuchs nodule between sarcoid, VKH, and sympathetic ophthalmia?
Now, this is a VKH, they call is a nummular choroiditis, and then they do have the only lymphocytic infiltrations over that one. So there is a very scanty literature of the VKH cases. Dr. Narsingh Rao did some work in the Japan on VKH patients, and he found what is called Dehlen-Fuchs nodule in VKH is not actual Dehlen-Fuchs nodule, is a nummular infiltrate.
Thank you, sir.